welcome to this episode of Family Empowerment by Agape Partners International. My name is Dr. Rhema Jacob, and I'm a board-certified psychiatrist practicing in the United States. The global pandemic has changed our world and shifted our focus towards mental health. There have been increasing rates of depression, anxiety, suicides, and substance use worldwide. In a recent study conducted in October of 2021, it was estimated that 13% of those residing in Kerala have some sort of mental health disorder, but only 15% receive treatment, and often this treatment is delayed by several years. During the pandemic, rates in the U.S. have increased from 1 out of 10 to 3 to 4 out of 10 individuals having some sort of mental health disorder. The age group that is the most affected in India and the U.S. is the 18 to 25-year-old population. This episode discusses the effects of the global pandemic on Indian Christians. I will be focusing on depression and uncovering 3 common myths that are discussed from a spiritual, cultural, and clinical perspective. Myth number 1 is that Christians are immune from mental health conditions. The Bible is certainly not silent about this topic. We see various Bible characters, such as Elijah, who had suicidal thoughts and ran away from Jezebel, feared for his life, and sunk into a deep depression. We see Hannah, who was mistaken by Eli as self-medicating by drinking too much alcohol, when in fact she was in deep sorrow that she did not have a child and was praying earnestly. We see Jonah, who wished to die when God did not destroy Nineveh. We see Jeremiah, who was known as the weeping prophet. And we see Job, who lost everything that he had and sunk into despair and did not receive comfort from his friends. We also see those who struggled with anxiety, like Moses, who was reluctant to become the leader and redeemer of the Israelites. We see David, who was worried and scared of the threats of Saul. And we see Gideon, who was afraid to become the leader, though he did become a mighty warrior. We even see there are 7 suicides in the Bible. We see King Nebuchadnezzar, who lost his sanity, and we see the man from the Gerasenes, who was self-harming and could not be restrained. Myth number 2 is that getting mental health care is shameful. Studies have shown that Indians are reluctant to get care due to stigma within our shame and honor culture, as well as our strong preference for faith-based healers or spiritual leaders over a psychologist, therapist, or psychiatrist. There's a lack of awareness in our community and often incorrect attitude or mentality. There is a fear of it impacting prospects for future marriage. Though Kerala is a leader in education, literacy, medicine, and other arenas, mental health is sorely neglected. Among Malayalis, it was estimated and researched that there is a significant fear of being placed on psychiatric medication amongst 46%, which is almost 50%, and 44% have a stigma regarding psychiatric illness or fear that stigma, and 43% believe in myths or half-truths. Kerala has a high number of anxiety disorders, and it is higher compared to the rest of the Indian subcontinent. And there have been recent studies that have shown that fears have shifted from COVID-19 to global events in recent months. Suicide was the second leading cause of death among individuals between the ages of 10 and 34 in the United States, and India, unfortunately, is among the leading nations with the number of suicides. These are sobering statistics, and they shed light on how dire and critical this issue is for our state of Kerala and our people scattered across the world. There are also unique hurdles faced by Indian women that I would like to briefly touch on. Some of these struggles include an inadequate number of mental health professionals who are culturally competent and familiar with the nuances of our culture, a lack of awareness, stigma, and the disadvantaged position of women within our society. Women also have unique struggles as they have multiple roles as mother, daughter, employee, and caregiver, amongst others. They they experience increased levels of stress and are much more prone or subject to domestic violence. We also see that there's many causes for depression in women because of interpersonal conflict, their caregiving burden as they have to take care of elderly parents as well as children, and being exposed to domestic violence, financial insecurity, and various changes throughout their entire life based on hormones, such as their puberty period, their pregnancy time, postpartum, and menopause. And often women outlive men, and widowhood can be another reason for depression. The third myth is that getting mental health care is scary and difficult. I'm here to remind you that it does not need to be difficult or a lonely process. And I'd like to discuss this specifically in the context of getting care for depression. It is estimated that about 5 to 12% of men will experience depression sometime in their lifetime, and 10 to 25% of women. In the world, it is estimated that almost 50% will experience some sort of mental health disorder in their lifetime. And depression is not merely sadness, nor is it grief, or nor is it something that someone can just simply snap out of. The ratio is a 1 to 1.7 male to female ratio, meaning that women are more prone to having depression. And the average age of onset is around 29 years of age, though there are many who could be older or younger than that age. The most important thing to consider is prevention. And anyone can have depression. It doesn't matter if they're young or old, male or female, rich or poor. I have definitely seen it all. And I would say that early intervention is key. There are many risk factors that can also lead to a propensity for depression, such as genetics, or we can also call it family history, history of substance use, trauma such as physical, sexual, or emotional abuse, a car accident, a divorce, bullying, or even going to war. A major life event like a move or some other type of stressor, even certain illnesses and medications can be causes. A history of previous depressive episodes also increases one's chance, as well as a history of suicide attempts. A lack of social support, in addition, relational, financial, and housing stressors can all increase one's risk for depression. And often what I see is a perfect storm of a variety of different stressors and risk factors culminating in depression. And the most important thing is prevention, like I mentioned, and that is because 5 to 10% can be later diagnosed with a more serious condition called bipolar disorder, and 7 to 15% unfortunately go on to commit suicide. Additionally, those with depression may also have coexisting or what we call comorbid conditions, such as anxiety disorder, substance use, and other conditions. To be formally diagnosed with depression, one must have at least 5 out of 9 of the following symptoms for at least a period of 2 weeks. The major symptoms are a sad or low mood. In children, it can be an irritable mood on most days, or many of the given days. The other cardinal symptom is losing interest or pleasure in one's usual activities, like being unable to get out of bed or go to work or take care of hygiene or do hobbies or do the normal things that would bring one joy. Other symptoms include a loss or gain of weight or an increase or decrease in appetite, sleeping too much or too little, feeling tired or lethargic, or even having thoughts of guilt, hopelessness, feeling helpless, or like a failure or a burden, which we would call worthlessness. Another common symptom is poor concentration and memory, or moving and talking too slow or too fast. And at its worst, it can lead to thoughts of suicide, with even specific plans of how one would want to end their life. And thoughts can include life isn't worth living, or I would like to sleep forever and escape. No one would care if I died, or what if I just ended my life? However, if symptoms are mild and noted early, many times mild symptoms can be treated with therapy alone, or in other terms, counseling. For moderate symptoms, therapy may still be considered, but one can consider antidepressants if necessary. For severe depressive symptoms, antidepressants plus therapy is recommended. And if symptoms are severe to the point of suicidal thoughts, someone may require hospitalization to keep one safe and to have the best outcome. Other things that are important besides therapy and medication would include healthy diet, such as one high or rich in fruits and vegetables, exercise, sunlight exposure, vitamins, checking labs to make sure one doesn't have any medical conditions like thyroid disease that can affect anxiety and depression, and relying on one's faith, of course, practicing gratitude, and learning coping skills. Coping skills specifically are things that a therapist can teach to help one become more resilient and cope with different symptoms and struggles or stressors in life. When it comes to medications, there is a lot of fear, but I would like to make it as simple as possible in this episode. Antidepressants affect various neurotransmitters and their levels, most emphasis given to serotonin, which many antidepressants can increase. However, the previous serotonin hypothesis is going away, and there is more focus on depression being an inflammatory brain disease, and reducing that inflammation is key, and increasing levels of BDNF, which is an important peptide that helps with neuronal growth and neuroplasticity. With antidepressants, it usually takes 7 to 14 days to start to see an effect, and doses may be adjusted at the 4-week follow-up, and any given dose usually takes 8 weeks to reach maximum efficacy or level of benefit for a given dose. And patients may be quick to quit medication because of side effects. But with proper education, it can be a seamless process because many of these side effects are transient and resolve on their own through time. Often, nausea, vomiting, and diarrhea can be seen, headaches, or sleep disturbance, whether insomnia or too much sleep. However, these are often transient side effects. Medication dosing can be adjusted to morning or bedtime to alleviate some of these things. And interestingly, nausea or vomiting may be a sign that the medication is acting on the gut serotonin receptors and will soon start to work on the brain receptors. Long term, patients need to be monitored for weight gain and sexual side effects or sexual dysfunction. However, these side effects only occur in a third of patients. There are some rare but serious side effects, one being that these medications can cause a manic episode, which is a type of mood episode seen in bipolar disorder, which is outside the scope of this lecture. Medication can also cause serotonin syndrome, which is very rare and usually only occurs when someone takes 3 or 4 medications increasing serotonin. Another rare risk is increased suicidal thoughts in those under the age of 25. This is highly rare, and the medication in the majority of cases decreases suicidal thoughts. However, warning is given with any antidepressant that this rare side effect may occur and to discontinue the medication if such a side effect occurs. The newer medications typically have fewer side effects, and there are various categories of antidepressants like TCA or selective serotonin reuptake inhibitors, SNRI, atypicals, etc. For someone experiencing their first depressive episode, 50% may never have another episode, while 50% may have another episode. During a first episode, 9 to 12 months of antidepressant treatment is recommended, and when it is time to wean medication, it is ideal to have already be in ongoing counseling or therapy. After a second depressive episode, 24 months of treatment is often recommended. And after a third depressive episode, someone may need to take the medication for several years, but this is case specific and patient dependent. One out of any three will respond to any given antidepressant. So sometimes it is necessary to switch medications or to augment, meaning to add another medication to provide additional benefit or to produce the outcomes needed to improve one's quality of life. After 2 failed medication trials, it is considered treatment-resistant or refractory depression. And after 5 medication trials, the chance of response is 1 out of every 5. However, there are many non-medication strategies that are available. Many automatically think of electroshock or electroconvulsive therapy, which is invasive and an older type of treatment. But nowadays, there are many new treatments, such as genetic testing, which can be done in the clinic or mailed to a patient. Often, I will mail a test kit to the patient. They will swab their cheeks with a Q-tip and mail the sample cells from their cheek. And the lab will run the test and attempt to predict with good probability what medications may work well for the specific patient based on their genetics and how they process and metabolize medications. Other treatments include ketamine, which is a medication that was once used as an anesthetic, but is now shown to be effective given intranasally or as an infusion to treat depression. Another treatment that can be given in the clinic that I offer patients is transcranial magnetic stimulation, which is a non-medication treatment that is non-invasive, given over 6 to 8 weeks, where a patient receives 20 minutes of magnetic therapy. So while they're seated, a helmet is placed on their head. They do not experience any significant discomfort, and they're able to watch TV or do other activities while they receive magnetic pulses. And the magnets are designed to help the underactive neurons in depression fire appropriately again and over the course of a couple of weeks to find improvement in depression by having effect from your own neurons firing appropriately and producing the neurotransmitters that you need without the introduction of any chemicals such as medication. In the United States in July, there has been also other developments such as the new 988 hotline, which is similar to dialing 911, but this line is specific for mental health crises or emergencies. Also, in the last couple of years, teleconsultations, as they're called in India, or telehealth, as they're called in the United States, has become very common. And these visits provide flexibility and convenience, as well as privacy, so that no one needs to know if somebody is receiving mental health care, and it eliminates issues with shame, stigma, and dishonor. I hope this has given you some light into how the treatments for depression vary with the types of symptoms and the various levels of care that are available for someone who may be suffering with depression. From the Word of God, we know that the peace that passeth all understanding is something that God promises us. He also promises the gift of a sober mind. He has not given us a spirit of fear, but of power, love, and a sound mind. And we need to understand that our answer may come in the form of a sermon or prayer alone, but sometimes for that proverbial thorn in our flesh, the answer may come through a godly counselor, a pastor equipped in pastoral counseling, or even a psychiatrist. I want to remind you that God is with us in the valley, and He wants you to be whole, body, mind, and soul. When we think back to those earlier Bible characters that we discussed, we see that God restored Job, and He gave him 10 other children, and He restored his wealth and gave him a double portion of everything. We see Elijah was given food by the angel and time to rest and a message of hope. In addition, Elijah was also strengthened by the company of Elisha, and he left bold and not the way he arrived in fear of Jezebel. We also see that Hannah received Samuel and went on to have 5 other children. We serve the same God today. He wants to restore you, and he cares about your physical as well as mental health. As his word reminds us, he who keeps his mind on you, you will keep him in perfect peace. I hope you've been enlightened with this knowledge and less hesitant to seek out help, and I hope you will share this information with others who may need it. And thank you for listening, and may God bless you with these words. Thank you.